understand the biopsy. Secondly, my question is, when I was in the academy, it used to be when you're presented with a tumor, the first step is just to take it out. Take out the tumor burden surgically. If it's resectable, then comes maybe chemo or radio, whatever. But this time I'm seeing, and I'm so frustrated. It's resectable, it can be seen in CT scan, it's resectable. But the surgeons are saying, no, do first chemo or radio, we shrink it first before we take it out. The rare doctors who can take it out without the aid of chemo or radio, like Dr. Magubat, they're rare now. But how do you, my question is, how do you do in the US? How do you go about it?
Okay. So, when they, the purpose of that being taken off is it depends on the stage. No, you have to stage the cancer because in the mainstream medicine it depends on what stage and the approach is different. When they give the chemo first, that means they're trying to debulk it without cutting it out. Because, like let's say, it's too bulky, it is more difficult to excise when you have a bulky tumor. So the goal is with chemotherapy, the cancer is going to shrink. But you know, my experience, even if there are some tumors and it is with a turbo cancer, after you resect, it becomes like even
fierce.
Yeah.
Oh, God.
This is what I'm saying to you, that the usual diseases, it's still the same, we call it the same, but they become unusual. And they're so unpredictable, and it's driving me crazy. Because you have to unlearn what you've learned. You know? So all my books are just collection, but they're all archaic.
Exactly.
Yeah? You have to become like, you have to be open. You have to be open and don't get frustrated because you have an expectation. No, we're learning about this with all of us. I know sometimes I said, I know a lot. And then I'm presented with this case. Darn, what happened? Why is it that? So you have to involve the patient actively, and you don't overpromise. Don't even promise. Not that I am saying, you're hopeless. But my purpose on that is so that the patient gets involved. The engagement of the patient is very important, 100%, 1,000%. But what I want them to do is have a very high expectation and a little setback. They're ready to, they're crying like crazy. They're like, I said, chill. And then I tell them, I don't promise anything. I will not pretend that I know everything. I know a lot, but I don't know everything. But I will do my best. It's the only thing I can promise you. I'll do my best to help you. Whatever comes out of it, comes out of it. And so you help yourself. And they're okay with that. And you know why they are okay with that? Because for the first time, they're coming to me and somebody is validating what they feel. No? Because everybody's getting gaslighted.
Yeah.
Oh, it's not that.
Yeah.
I tell them, go back to that doctor.
Yeah.
Tell them, and then tell them I'm willing to talk to them. No, you just go with a thing. You want to talk? Talk. And then the biopsy, it depends on what cancer. Dr. Anna, the reason for the biopsy is because they try to, it depends on what kind of cancer. The treatment is also tailored to that. Like let's say, how are you going to treat an ER positive or estrogen receptor positive? It's a different ballgame when it's negative. No? So that's what they need to do. That's why sometimes, but I don't biopsy kidney. I do not biopsy. I don't want to biopsy the pancreas. The kidney, when you biopsy that, you're likely to spread the cancer.
Yeah.
And then the kidney, you can see it. I mean, it looks nice. I have kidney cancer that I just saw last week. I gave my blessing for him to get chemo, but this is what you're gonna do. Keytruda. You guys can research that. Keytruda is like, they're giving it like candy, the oncology. So what I do when they have whatever chemotherapy it is, whether it's the standard chemotherapy or the biologics, we call that biologics, like, there's such a thing because they use almost like a monoclonal. It's supposed to be very specific and will only attack the cancer. I do the IV vitamin C. If they don't have G6PD deficiency, I give the maximum dose before, a couple of days before the chemotherapy. And then after the chemo, they come back and I give another one. So I sandwich it. What's the reason behind that? Because the IV vitamin C will prevent them from getting side effects. And then when they come back, they have the chemo and you give them the IV vitamin C. It's the best combination because it will melt the tumor and then address the stem cell, the cancer cells. Well, theoretically, that's what we know. And then, whatever. Yeah, the ivermectin, when you take ivermectin, the tumor actually becomes more sensitive to the chemotherapy that you're going to use. Somehow it changes the configuration, whether it's a TNF level or something else, receptor, just work. Then,
Yeah, the reason I asked it because I used to discourage biopsy because it causes inflammatory oncotaxis, right? And the thing that you said, they do surgery and
yeah.
the whole thing blew up, and it recurs more even worse now. So biopsy also doing the same thing, so I tend to discourage that. But if it's for diagnostics, yeah. But if a tumor is obviously resectable, it can be taken out right away.
Yeah.
I would not require the biopsy.
In the lungs, that's what I do. They have a nodule. Once I do the PET scan, it lights up. No more biopsy. Go, have it removed, and then I take it up from there. I give them, whatever. Aside from the IV vitamin C, I use other stuff. NAD, alpha-lipoic acid with palladium. I use artemisinin. Sometimes there are some people requesting for even methylene blue. The methylene blue is very good because it increases the blood flow. And the delivery of oxygen is very good. Methylene blue. But I usually use my chronic numbers.
Doctor, do you use carbon dioxide?
Yeah, but we need to discuss the formula. We're all over the place.
We have an expert here on chlorine dioxide.
Alan,
right?
Yeah, somebody told me about you. Oh, Rosanna. I think Rosanna was the one and said, no, we should, you guys having the experience, you have to put it out, you have to help. I mean, who knows, probably if you put together a protocol, talagang mawawala na yung chemotherapy. The chemotherapy, I have nothing good to say about that. Because where do you see a treatment that is a 93% failure rate? Now you're wondering why there is no cure for cancer? Yeah. That's the reason why.
Business.
Yeah.
Business.
Very good.
Yeah. Thank you so much for encouraging us, and just so blessed to see doctors who are like-minded. Thank you so much. The question is, have ever compared for the 5 years of your study the virulence level for both the infected and the vaccinated?
Okay.
Is there a difference even how you manage it?
Yeah. The management is almost the same. I'm going to tell you. I'm not supposed to be telling you this is part of the study, but I'll give you an inside scoop. The infected have more autoimmune. Their autoimmune is more randomized, meaning they can develop 3 or 4, even sometimes 5 types of autoimmune disease. And then, but the difference is like if the infected is developing it 70% of the time, the vaccinated is like 55 or 60, same difference, right? But if you're very strict in terms of the absolute number, I think it might change because we're not done analyzing or collecting the data. It might be neck to neck or something. Because you have to remember, the vaccinated are continuously producing spike protein. Continuously, we have proof with that now, because as I said, I was involved with this group of people that we're going to develop the testing for spike protein itself. Because right now what we have is the test only for the antibody to the spike protein. It's not the spike protein itself. We're measuring the response of the immune system. And the assumption is if it's very high, then the spike protein antigen must be very high as well. It's the spike protein antigen that's causing the disease. So you want to know exactly where you are. But we don't have that. And it's very difficult to get it approved. Why? What do you think why? It's so incriminating. They said, oh, it disappeared. Really? Really? Yeah. You're cute. 5 years. The very first one who found out that the spike protein is staying is actually Dr. Patterson. He used to be with in California. What's that university there? It's very woke. The one, it's not Oxford. Oxford is in London. The other one, UC, and there's another one. But anyways, yeah. No, Yale is in Connecticut. He was the one. He was the one who noticed it first, that the spike protein was actually in the monocyte, the white cell in your blood vessel, in the blood vessel. And mind you, every time that monocyte moves, you're gonna have inflammation. So, remember, everybody was like, oh, I exercised, then I'm dead the next day, the post-exertional malaise. Because the inflammation goes in when all the monocyte like marching all over. But it's in that, and you know what's happening? The monocyte in the blood or in the blood vessel, they only have a certain lifespan. They have to die after, I don't know, so many days. But when they are parasitized by the spike protein, they become zombies. And then they're just like, oh. They're living longer. And if you do not detoxify yourself, when the zombie cell dies, then the spike protein will come out and will just parasitize the next cell. No? Isn't it a very good design? It's like they make your cell like a car. Yeah.
You can also ask for an ultrasound to see your spleen.
Yeah.
Able to see splenomegaly.
Yeah.
Theoretically, right?
I use all the tests, depending on what I'm looking for.
Oh yeah, you are telling us that it harbors the parasite in the monocyte. And as we all know that the graveyard of the red blood cells is the spleen, then somehow, theoretically, those who have been infected with this kind of viruses have splenomegaly.
Not all of them, but yeah, they do.
Yes, and after having splenomegaly, then they will come your ITP.
Yeah.
So another form of...
Another problem. But you know, when they are having splenomegaly, they're
I
having...
had patients with bowel ischemia before.
Yeah.
When I go back to the history, then it's really about the vaccine.
Yeah.
So other than that, there is no twisted bowel.
Mm-hmm.
When I open up the segment of the bowel, it has to be resected because it is dead.
Yeah. You see, that's clots.
Yes.
That's clots.
Classic.
Either the red clot or the
Yes.
white clot. Yeah. There's always this micro-clotting going on. And so, that's why it becomes chronic, because the organ doesn't die right away. It's just that the blood flow is reduced. How can you perform? I mean, I'm asking you to work 24 hours a day and I'm not feeding you. So basically, the bowel becomes ischemic. And if it's a full-blown obstruction because you form a significant amount of blood clot, then the organ dies. Yeah. Yeah.
My question. Hi, Ayan. My question, Dr. is ano, many of us have loved ones who are not awake yet. They are probably awakened already, you know. Now, ang iniisip ko, to get my loved ones, you know, awakened, ano ba the best way to get them, ano? Now, iniisip ko, live blood analysis. There was a 2023 Italian study that showed that 94% of vaccinated individuals who have symptomatic problems or presented that have blood abnormalities. Now, in the absence of spike protein test or antigen test, may be very expensive. Pwede ba, tingnan na lang natin yung itsura ng dugo. Once they see that, you want proof, look at your blood. Something like that.
Absolutely. I mean, you just have, this is what you do. Don't give up. Don't give up. Trying to encourage them.
Maybe, bigyan sila ng regalo, makiklaim lang nila pag live blood analysis. Anyway, it's not that expensive naman eh, di ba? So live blood analysis.
Yeah, you can see because in the live blood analysis, the most common finding is that will do for many. You know, your blood, they stick together. And there are only very few things or reason why you will do that. And it's the presence of the toxin. But they can challenge you. How do you get to that?